Test 1 2 1 2. Test 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 test. Test 1 2 1 2. Test test testing. Test 1 2. Test test. Test 1 2 1 2.
afternoon, everyone. My name is Aaliyah, and I'm the Data and Resource Coordinator with Forge Breast Cancer Survivor Center. Forge is actually a sponsored and supported organization with St. Vincent's, and we're housed at St. Vincent's East in the Foundation office. And we provide supportive services to breast cancer survivors, co-survivors, their loved ones, and the healthcare professionals that serve them. So what we do is we offer a myriad of services to breast cancer survivors, like I said, and those services vary depending on the individual's needs. So we provide all of our services on the phone or out in the community. We don't actually have patients come into our office at all. The majority of our services are provided directly by phone. So we offer individualized plans for breast cancer survivors. They can call us and get an assessment done where we can figure out what their needs are, what their gaps in their care are, what sort of support system they have, and then we can work with them and different resources in the community to meet those needs. Some things that we offer that are really popular are helping connect them with financial assistance resources, providing professional and legal supportive counseling, so we can connect them with a lawyer if they're having issues with workman's comp, for example. We can connect them with professional counseling if they're in need of counseling services. We can connect them with budgeting counseling in case they're needing to work on their budget so that they can afford the cost of their cancer. And then we can connect them with any other resources that we know of that might be helpful to them. We have something called knitted knockers, and this might be especially of interest to anyone who's working directly with breast cancer survivors. Knitted knockers are knitted prostheses that are free of charge that survivors can use instead of purchasing an expensive prosthesis. And we offer those out of our office as well. So like I said, there's really not much that we can't provide. Individualized plans are our most popular service. We also have support groups that are offered monthly, and those are in Blount County. And then we have other classes as well. We have a month or quarterly now gardening class where we tie in a survivorship topic with a gardening topic, and survivors come to the class and get to make something really fun. I think, for example, our upcoming class is going to be a wildflower arranging class, so everyone's going to make a wildflower arrangement, and they're going to talk about physical therapy and the benefits of exercise. And then we also have a monthly exercise class, which is offered with our partner Benchmark Physical Therapy, and that's out of their Homewood Clinic. And survivors can go to that class and do a different exercise program. So I think the upcoming one is about yoga. And you can get information about all of those on our website, which is forgeon.org. In front of you, you have a one-pager that just sort of lists all the different services that we provide and examples of things that we can do for survivors. And there's also a copy of our brochure there as well. Does anyone have any questions, or is there anything I can answer for anyone? No? Yes.
Could you make an announcement for the people online that the speaker is late, but they will be here?
Sure. For anyone who's listening online, our speaker is actually running behind, but they will be here shortly. Okay. Thank you.
don't want to blow the deck.
That's a problem. Yeah.
Yeah, you can come over here. I've got to get some mic.
You'll have two mics, one for the camera and one for the frame.
All right, let's do it.
Pop that one in your pocket.
Yep.
You put this other one on you. I need you to stay behind the podium.
Yep.
Because we're live streaming, so
Yep, you bet.
it took you to the wrong place, huh?
Yeah, as usual. So this is Grand Rounds, are you oncologists? Who are these people?
Grand
So-
Rounds, yeah.
Just medical?
Yeah.
Okay, got it. All right, perfect. All righty. Cool. All right. Well, thank you all for your patience here. We'll get started. I'm Adam Brusky. I'm a professor of medicine at the University of Pittsburgh. And I'm probably not the first person who's made the mistake. I was told to go to regular St. Vincent's downtown, and I was all set up to do it. And I found out that it was east, which is 20 minutes away. So sorry about that. But anyway, this is a general medical audience. But I mean, I think this is something for everybody. This is, we're going to talk a little bit for the next 20, 30, 40 minutes about the treatment of metastatic. Okay, let me know when you're, hold on. Make sure we're okay. I'm not feedbacking. Are we okay?
Let me see the room, this mic. Let me see the bottom part.
Okay.
Nope, wrong one. Not that one. Sorry.
Okay.
It's full battery. Huh? Got full battery.
All right, is that better? Okay, good. All right, that works. Anyway, so you know, for general medical audience, we're going to talk about the treatment of breast cancer, in particular metastatic breast cancer, and there have been a lot of changes in the last couple of years. And I think that some of you in your practices, actually, regardless of what kind of physician you are, will actually see women with metastatic breast cancer, because with some of the new advances we have, women with estrogen receptor positive metastatic breast cancer can live upwards of 5 to 10 years now. And we're going to talk a little bit about that today. So anyway, you have the evaluation in the syllabus. So one thing they always want me to do, and it's really hard to see from back there, is talk about the staging for breast cancer. Again, for a general medical audience, I think that, could someone give me a glass of water too while you're at it? For a general medical audience, the staging of breast cancer actually has changed a bit, but the anatomic stages that we do basically is based on the size of the tumor. A tumor 2 centimeters or less is T1. 2 to 5 centimeters is T2, greater than 5 centimeters is T3, and with local invasion it becomes T4. Nodal status is depending on the number of nodes, so 1 to 3 nodes is N1, 4 to 9 is N2, and greater than 9 is N3. And obviously distant metastatic disease is anywhere else in the body other than the ipsilateral axillary nodes. One thing that's happened over the last couple of years is that we now are using kind of multi-parametric tests like Oncotype DX and MammaPrint. These are tests that actually can look at the cancer and determine its risk of distant spread at 10 years. And we've incorporated those into the staging system. And what we do now is when someone comes in with early stage breast cancer, if their Oncotype DX is low, oh, sorry, could you, water? Oncotype DX, if their Oncotype DX is low, they actually now are stage 1 and not stage 2 or 3. So it's like one of the big things, but we wanted to kind of just emphasize that for this. So this is kind of the landscape of the treatments for estrogen receptor positive breast cancer, and in particular metastatic breast cancer. Tamoxifen was developed in the late 90s. Thank you. Late 90s. Actually, the late part of the 1970s, actually as a fertility drug. It was rapidly abandoned because it caused birth defects. But it actually, because it bound the estrogen receptor, actually came into widespread use. We couldn't get this drug approved right now by the FDA in 2019, mainly because it caused birth defects. And so it's really interesting how it was approved almost 40, 50 years ago. Starting probably about a little over 20 years ago, people realized that estrogen needed to be aromatized by enzymes that were in the periphery. And not only in the adrenal gland. We used to use a drug called aminoglutathione to reduce the production of estrogen, but it caused adrenal failure. Anastrozole, which is a non-steroidal aromatase inhibitor, actually inhibited the peripheral aromatase. And after that was approved, it became actually the standard of care for postmenopausal breast cancer. That was followed by fulvestrant, which is an estrogen receptor downregulator. We'll talk about that in a little bit. We didn't really know what the dose was of fulvestrant and actually realized the dose about 2012 and was approved. Everolimus is the first of several targeted therapies that were approved. It was called an mTOR inhibitor, binds to a particular pathway in breast cancer cells. Palbociclib is a CDK4/6 inhibitor. We're going to talk about that in great detail. And ribociclib and abemaciclib, 2 other ones, have been approved. And I think that the fact that we have these targeted therapies now in the latter part of this decade really has changed the natural history of this disease. So looking at kind of where we are, let's just kind of go through, we can do this quickly. I don't know if you have this activity survey there or not, but I think in the interest of time, we'll probably skip through that. We'll talk about that at the end. We'll just talk about the cases at the end. So basically, the standard of care for metastatic breast cancer for many, many years has been either an aromatase inhibitor, which is this drug anastrozole that inhibits the peripheral aromatase, or fulvestrant, which is again an IM injection that you get monthly that actually dissolves the estrogen receptor within cells. And so obviously as medical oncologists, we're very interested in trying to figure out which one was best. And we did this trial where we actually took women, gave them anastrozole or anastrozole in the combination of anastrozole and fulvestrant. And actually adding fulvestrant did improve overall survival, as well as what we call progression-free survival, that is survival without radiographic or symptomatic progression. And this actually really for a long time, at least for several years, was the standard of care for this disease. Again, there was other trials that are very similar to this, anastrozole versus anastrozole and fulvestrant that didn't show much of an overall survival benefit. This overall survival benefit was about 3 years of these women. And that's because in this case, women had been pre-treated already. They were a little bit more advanced than the women in the prior trial. So given the fact that really where we were was probably about 3 to 4 years of survival of most women with metastatic breast cancer, we really tried to develop other agents. And CDK4/6 inhibitors were developed because of this. There was 3 of them: palbociclib, ribociclib, and abemaciclib. And what these agents do, unfortunately we don't have a cartoon to show that, but what these agents do, palbociclib, ribociclib, and abemaciclib, is they actually inhibit an enzyme called, or inhibit a protein called CDK4. CDK4 is required for progression through the cell cycle. What happens is a protein called RB that's bound to another protein called E2F. And what happens is that RB needs a phosphate, needs to be phosphorylated to release E2F and have the cell cycle kind of go on and have the cells proliferate. And so the idea is that that's under very tight control, that phosphorylation of this RB protein. And so the idea is that things like CDK4/6, which is a cyclin-dependent kinase, they're under control by various kind of factors inside of cancer cells. But if you can somehow inhibit that phosphorylation of CDK4, you can't inhibit RB. So RB can remain stuck, and the cells remain stuck in the cell cycle. They're not able to replicate their DNA and proliferate. So that's kind of the idea behind CDK4/6 inhibitors. And there were several trials actually of these. The first one was a small randomized phase 2 trial of actually women with first-line metastatic breast cancer. These women had had disease to their lungs, liver, or bone that was estrogen receptor positive but had no other therapy. And basically what happened is that these women were given either a aromatase inhibitor, letrozole, or letrozole and palbociclib. And as you can see here, it was very surprising to all of us because a lot of us didn't believe this was going to work, actually doubled this progression-free survival. Is there feedback now again? I think I'm hearing.
It's not feedback.
Oh, are we okay? Can I keep talking?
Yeah,
Okay.
something with their VA system.
Okay, so the bottom line is that it doubled the progression-free survival from about 10 months to about 20 months. And you can see here, there's a group of patients here, out about 3 years, almost 30–40%, that hadn't progressed. And these women actually continue out for many, many years. And so we really have taken where the vast majority of people who got just the letrozole alone actually progressed and had to go on to something else. It's interesting, though, even though you had that long period here where you had all these women that didn't progress, still the overall survival really didn't change that much. And this is kind of a mystery to a lot of us, and we're still not quite sure why that is. But the bottom line is that there still was no overall survival, probably because the women got a lot of different things after they progressed. So this led to the design of very large trials. That was a small trial of about 160 women. That actually resulted in FDA approval of this drug. It's very surprising that the US FDA actually approves a drug based on a very small 160, 170 patient study. But because of that, actually, the FDA required a larger study called PALOMA-2, and this is a study of 666 women who had had no prior treatment for advanced metastatic breast cancer, got actually letrozole and a placebo and palbociclib. Other agents around this time also were tested. Ribociclib, which is a drug made by Novartis, it's a little bit different drug, as we're going to show you in a minute, also had a large clinical trial, about 660 patients, again getting placebo and letrozole or ribociclib and letrozole. So 2 large, very large trials. And not surprising, interestingly enough, these trials are actually almost superimposable. You know, what we had here is that, you know, basically most women, just with endocrine therapy alone, actually can live without progression a little over a year, about 14 months. And when you add a CDK4/6 inhibitor to them, it actually doubles the progression-free survival. And the interesting thing, it didn't matter which one. Pretty much ribociclib, palbociclib, pretty much gave the exact same result here, doubling it. But the important thing here is that women now go upwards of 2 to 3 years without requiring another therapy. These are women who come in with widespread bone disease. A lot of them have disease in their lungs, their liver. You know, you take a look at them if they show up in an emergency room or your office and say, gosh, you know, this is really bad. Yes, eventually they'll die of their cancer, but you really now have stabilized their cancer and they can live a very long time, you know, at least relatively for us as oncologists, a very long time without progression of their disease. Now, there was one other drug called abemaciclib. This is made by Lilly, also is a little bit later to market. Again, had a very large trial. About 500 women were randomized to receive placebo plus anastrozole, an aromatase inhibitor, or abemaciclib. Again, a large randomized trial here. And again, showing basically the same thing. In the placebo arm of the aromatase inhibitors, about a 14.5-month progression-free survival, which was doubled when you added the abemaciclib. So all of these agents kind of work the same. They actually work in premenopausal women as well. What we generally do with a premenopausal woman who has metastatic breast cancer is that we take her and we make her postmenopausal by either removing her ovaries or giving her an LHRH agonist. So this is a trial where premenopausal women actually received an LHRH agonist and then got tamoxifen, a non-steroidal aromatase inhibitor, which was the standard of care with or without, in this case, the CDK4/6 inhibitor ribociclib. And again, just like all the other trials, this had a progression-free survival about 13, 14 months, which was doubled when you added ribociclib. So this worked actually for premenopausal women as well. So all women receiving these agents actually had a doubling of their progression-free survival. And again, out here, you're talking, you know, 2 years, 3 years, 4 years, a substantial fraction of women have not progressed. You know, one question people always ask, well, that's good, but does it really affect patients' outcome in terms of quality of life? And the short answer is it really doesn't. It improves it a little bit. Again, I've never been a real big fan of quality of life studies. I mean, I think that you tell a woman with metastatic breast cancer that she's actually not progressing, and she becomes really happy and her quality of life gets a lot better. So you can never take that out of the equation, but you can see here at a minimum it didn't make the quality of life worse, and in fact actually made it somewhat better. So this is a case where patient-reported outcome actually correlated with the stability of the disease and actually the other more objective signs of stability. So, you know, the issue here is, you know, that's for first-line therapy. So most women who come in the door, you know, with relapsed metastatic breast cancer will get a CDK4/6 inhibitor and an aromatase inhibitor. But what about the people who are already on them? So, you know, you have a woman, say, who comes to see you, you know, she's got a lot of lymph nodes involved, say you give her chemotherapy, she's got estrogen receptor positive early stage breast cancer, and generally, if she's postmenopausal, we'll put her on an aromatase inhibitor. What happens when people progress on an aromatase inhibitor? Well, for many years, and actually I participated in this trial over 13, 14 years ago, what we did is we gave patients fulvestrant, or another drug called exemestane, which is an aromatase inactivator. It binds to another part of the aromatase enzyme. And as you can see here, the progression-free survival isn't that great. It's about 3 or 4 months. So this is kind of typically what we see, unfortunately, kind of in therapies that don't work as well as we would like them to. And so what do we kind of do with that? Well, one option was to add a CDK4/6 inhibitor to those women. And in fact, this is a trial where women who had progressed on an aromatase inhibitor, so this is now second-line therapy, received either fulvestrant and a placebo, this is the standard of care, or added palbociclib to the fulvestrant injection. And in fact, it almost doubled the in fact, almost threefold improved the progression-free survival from about 4 months upwards of 9 months here. You can see here, really kind of improved it. And so this now has become the standard of care for this. Other drugs did the same thing. Monarch 2 is a trial, very similar. Women who had progressed through an aromatase inhibitor actually received fulvestrant and placebo, or fulvestrant and abemaciclib. So again, they got this, the CDK4/6 inhibitor, and in fact, in this trial, basically the same thing happened. It went from about 9 months to about 16 months. The reason these numbers are in absolute terms higher is because this had a lot of women who had progressed on their adjuvant therapy. So they were on an aromatase inhibitor kind of for early stage breast cancer. They progressed and then they got fulvestrant with or without the CDK4/6 inhibitor. So you can see when a woman walks in the door, she's going to basically, and you put her on fulvestrant and say a CDK4/6 inhibitor, she's going to basically have a progression-free survival at least of 16 months, probably a little bit longer. One other thing so that's the second line therapy. What about beyond? Well, one thing we found is that these drugs work even if a woman's been heavily pretreated. So we have a lot of women, I run a very large breast cancer practice in an academic medical center, and so we see a lot of women who come in have been through multiple therapies. So what tends to happen with these ladies is that they get like 3 or 4 different hormonal therapies, then we give them 3 or 4 different chemotherapies, and they progress very, very slowly over time. And so what a lot of us tried to figure out is maybe we should give these drugs as single agents after they progress through everything. And in fact, Monarch 1 was actually getting single agent abemaciclib twice a day. And this, if you guys are not familiar with this is called a waterfall plot. We have this in oncology a lot, especially in early phase trials. These are actually the percent of people who have progressed. This is the degree of progression of their lesions. We do bidimensional measurements or unilateral measurements and actually see how much they progress. And you've got to go over 20% to actually have progression, over 30% down here change to have a response. But you can see here a vast majority of people have stable disease. And in fact, if you have this inflection point and it goes to the left, that means the drug actually works better than we thought it would. And in fact, the vast majority of patients, only about a quarter of patients here progressed. The vast majority had stable disease or actually improvement. And when you take a woman like this and the overall survival, we didn't show this here, this clinical benefit rate is stable disease plus response is about 40–45%. And the overall survival of these patients is about 18 to 22 months. And most of them have had 5–6 therapies before they even went on the trial. So we all got very excited about these drugs because they work at any stage of, or any kind of line of metastatic breast cancer. So they really have changed kind of the paradigm. So then when we talk about kind of resistance to endocrine therapy in this disease, basically, it's what we call really acquired or there's de novo resistance where they just don't respond to anything. Then there's acquired resistance, meaning they've been on at least 6 months of endocrine therapy with stable disease. And there's a variety of reasons people become resistant. They activate other growth factor pathways in the cell. You can see here you have estrogen binding to its receptor. You have all these other pathways that can hijack it, like the PI3 kinase pathway, proteins called AKT, mTOR, et cetera. You can get a mutation in the receptor for estrogen that actually makes you insensitive to aromatase inhibitors. About 1/3 of people have that happen. Then there's changes in the microenvironment of the tumor that are a little bit harder to figure out, but I think people are starting to get an idea of what happens there as well. And again, I think that we're actually learning a lot more. And I think that it turns out that these are probably the reasons that patients become resistant. There's amplification of something called fibroblast growth factor. That seems to be a common pathway, about 30 to 40% of patients. Because what we do now when people become resistant is we do DNA sequencing on their cancer to try to figure out what's going on. And it turns out probably about 1/4 of the time they have amplification of this FGFR. Now, unfortunately, we don't have very good drugs against that yet. We've tried to develop them over the last probably 5 to 10 years. Most of the trials have been unsuccessful, unfortunately. So we have other things that can happen. Again, mutations in the receptor for estrogen, amplification of a protein called MYC, amplification of cyclin D1, et cetera. And so for this reason, what happens is that, so if there's resistance at all these other areas, maybe we can block it. So in other words, if there's, overexpression of these proteins, maybe we can have something that binds to mTOR, for example. And we have that. We have a drug called everolimus. So this is actually everolimus in hormone-resistant breast cancer. It binds to the mTOR protein. And as you can see here, both with tamoxifen or with, in this case, exemestane, an aromatase inhibitor, or tamoxifen, when you add the everolimus to it, you can see here you actually have an improvement in the patient's progression-free and even in some cases overall survival. So the thing is that you actually have a way to overcome resistance by targeting one of the downstream proteins here. We did a trial also that shows that these drugs work with fulvestrant. And in fact, this is now probably the standard of care. Most women who have progression now on, say, an aromatase inhibitor and a CDK4/6 inhibitor get fulvestrant and everolimus based on this data that was actually presented a few years ago, published in one of our journals last year. So people have tried a lot of other things. They've tried other drugs very similar to everolimus. There's vistuserib, which kind of binds kind of like everolimus to mTOR. There was a trial comparing it that actually, unfortunately, didn't work. So there's a lot of complexity here to this mTOR protein, to resistance, that we kind of don't really understand that well. So finally, you know, I just want to kind of finish. You know, we've talked about CDK4/6 inhibitors. We've talked about resistance to them. So what about the side effects that occur with some of these drugs? So I will give you kind of a question here in a case. We're not going to go through it in the interest of time. But a 65-year-old woman, a postmenopausal woman, was treated with exemestane and everolimus. 12 weeks into therapy, she developed a rash and had mild dyspnea on exertion. So her chest ray showed apical changes consistent with pneumonia or pneumonitis. So what do we do here? You know, should we scan her? Maybe she has progression. Should we continue her meds? It's probably just have a cough. Should we give her antibiotics? You got pneumonia, or should we give you a pulmonary consult? Okay, so the question is, what do we do here? So the next question, very similar, is a patient gets CDK4/6 inhibitor and letrozole. 3 weeks into treatment, she gets fever, diarrhea, and an episode of syncope. In the ER, she's got a temperature of 101, and she's a little hypotensive. And so what's going on here? Does she have neutropenic fever, heart block, diarrhea, or everything? So these are the sort of things, you know, what are the complications of these drugs that can happen, and they're not benign. Now, you can't really see here, but what this basically shows you that with CDK4/6 inhibitors, really regardless of the CDK4/6 inhibitor, the major side effect is neutropenia, okay, from both Paloma, let me see where I'm going here, okay, is neutropenia. So that it really is a neutropenia, and again, thankfully, the incidence of fever and neutropenia, or neutropenia and sepsis, is extremely low with these agents. So it's really nice that when someone gets neutropenia, it really is a lab test, and what we say is that if you develop grade 3 or grade 4 neutropenia after 14 days of being on this drug, you hold it till you resolve to grade 2 or less, and then you start it at a lower dose. And that usually kind of alleviates the neutropenia, and patients generally can live with a neutrophil count of about 750, 1,000, 1,200 without having any side effects. So people really only get fever neutropenia when they have persistent neutropenia under 500, grade 4 neutropenia, for a couple days. So neutropenia really is a major toxicity. It's easy actually to kind of manage. Other side effects are actually fairly low, with the exception of abemaciclib. So ribociclib and palbociclib is neutropenia. Abemaciclib, it turns out, is diarrhea. Abemaciclib has less neutropenia but more diarrhea. And in fact, the incidence of grade 3 diarrhea here is about 13 or 14%. So the other major side effect that you can get with these agents actually is mucositis, and that tends to occur with everolimus. So with everolimus, basically, if you look in most of the trials, about probably, it looks like here, probably about 7 to 10% of patients get a really bad stomatitis. Grade 3 stomatitis you really can't eat, and you almost need intravenous fluids. However, what we found, if we give people steroid medication, a steroid mouthwash, twice a day, actually the incidence of grade 3 mucositis goes away, and in fact almost nobody gets stomatitis. So we've actually kind of figured out, both by dose reduction in the case of CDK4/6 inhibitors, by steroid mouthwash with everolimus, we actually were able to alleviate a lot of this. One other thing that does happen with everolimus, and this is why that case was presented, is that probably about 4 to 6% of the time you can get a pneumonitis that can actually progress to be life-threatening if you don't recognize it, and can actually look like progressive metastatic disease. And so what we tend to do is that if someone comes in with shortness of breath on everolimus, is that we do a CT scan and look to see if it looks like the typical pneumonitis changes. And so this woman that we presented probably should have had a CAT scan, and had she had a CAT scan, it probably would have shown pneumonitis, which is generally reversible when you stop the everolimus. So what about some novel agents? So, you know, this is kind of where we are now. So first-line metastatic disease, you can see here, we've improved the standard from about a year to about 2 years. We've improved kind of progressive disease, regardless whether it's exemestane and everolimus or fulvestrant and CDK4, up to about a little under a year, 8 to 9 months. But can we do even better than that? And I think that we've tried. We now have drugs, again, one of the proteins that's abnormal about probably a third of the time, or 40% of the time, is PI3 kinase. And we have drugs that actually inhibit PI3 kinase. We started with kind of drug called buparlisib. Didn't really work that well, kind of marginally improved progression-free survival, but had fairly severe side effects, including diarrhea and hyperglycemia. And so this one was abandoned. Again, you can give this drug after aromatase inhibitor, still very minimal changes, about a 1 or 2 month progression-free survival. Another trial, Sandpiper, actually did not show any improvement as well, a large phase 3 trial, but there was a recent phase 3 trial that was announced about 6 months ago called SOLAR-1, where women who actually had PI3 kinase mutated breast cancer, so we sequenced their breast cancer to see if they had a PI3 kinase mutation in it, and then we gave them fulvestrant with or without alpelisib. And in this trial, which was presented, I think we have the data, there we go, the data shows that adding the PI3 kinase inhibitor in with PI3 kinase mutations actually improved the progression-free survival for about 5 months, as you can see here, to about 11 months. So this drug will likely be approved by the US FDA within like the next month, and will actually now be part of our armamentarium of what we can do. So there's actually a lot of, because this is working, we're now trying these drugs in a broad variety of settings, both in the early stage neoadjuvant setting, patients are getting talcelicib and letrozole, and a variety of settings in the second-line metastatic therapy or greater, where we're trying to use these PI3 kinase inhibitors. What about combining agents together? So, you know, if you have a block here and maybe a block here together, maybe you'll get some synergy. So people have tried to do various trials, adding ribociclib and everolimus to exemestane, or adding, in this case, and you get some benefit. You can't really see here. This waterfall plot is about in the middle. You get some response, really not great, very toxic. Same thing adding a PI3 kinase inhibitor, alpelisib to ribociclib. Again, you can get some benefit here. It's hard to know whether this is, you know, you get this with either one as opposed to both together. So this is being explored. The combinations are fairly toxic, and we're not quite sure where that's going to go. As I said before, there are FGFR inhibitors. It's present actually in about 15 to 20% of breast cancer. That's estrogen receptor refractory, and you can see here if you're overexpressed, you tend to do worse. And so we actually now have drugs that are at least active in animals, and now we're trying a variety of agents. This is an FGF inhibitor that actually worked in animals, and this is actually now being tested in clinical trials as we speak. So we're trying actually to target FGFR. This is probably, if we can figure out how to do this, we likely will improve progression-free survival and probably overall survival in women with metastatic breast cancer probably by another 6 months to a year. But again, we still haven't found any agents that work really well. They all seem to work really well in animals, but when we try to put them in humans, we really don't seem to do that well. And again, this is the trial right here that I was talking about. You can't really see it here. It's women with FGFR amplifications who have progressed through a variety of agents, are given either a CDK4/6 inhibitor and fulvestrant, or an FGF inhibitor, CDK4 inhibitor, and fulvestrant. So there's a lot of different trials out here that are targeting it. The last thing I think really to talk about, obviously, as we know with all cancers, is immunotherapy. In triple-negative breast cancer, that's breast cancer that's negative for the receptor for estrogen, progesterone, and HER2. These checkpoint inhibitors, which actually inhibit a protein called PD-1L1, have been approved in breast cancer now. So atezolizumab, which is a PD-1L1 inhibitor, has been approved. The idea behind, again, you can see here, is that you get a reaction to the tumor itself, to tumor antigens, but the tumor itself and the microenvironment actually inhibit the proliferation of T cells because they actually have this protein called PD-1 that binds to a PD-1L1. And so if you can actually interrupt that with an antibody, interrupt that binding, you can actually turn on the immune system. And this has worked very well in lung cancer, bladder cancer, melanoma, renal cell cancer, recently other cancers. And we've really tried to figure out whether it works in breast cancer or not. It doesn't seem to be that big a deal in ER-positive breast cancer. It's mostly triple-negative breast cancer. But on the other hand, we're still trying to work it out and combine this. And so the idea is that, you know, what we do is we give patients hormone therapy and CDK4/6 inhibitor for a number of months. We allow immune infiltration into the tumor. And then what we do is give them a checkpoint inhibitor to try to kind of boost that immune response. And there's a variety of trials that are going on right now. Other trials that are going on are actually, we have histone deacetylase inhibitors, atinostat, which actually inhibits the winding of chromatin. This actually had a survival benefit when compared to placebo. Actually, it's hormone therapy. with or without atinostat. It had a survival benefit. This is now this is a randomized phase 2 trial. This resulted in a large phase 3 trial that's currently ongoing, but unfortunately, and actually just close to accrual, and hopefully we'll have some answers to whether HDAC inhibitors work in hormone receptor positive metastatic breast cancer. This is just the trial here, ECOG 2112. This trial actually was exemestane and placebo versus exemestane and atinostat in about 600 women. This trial literally just finished accrual probably last week, and hopefully we'll have the results of this in a few, probably a year or so afterwards. And again, this just shows you, like all tumors, we try to do DNA sequencing to try to get more insights into this. And really, if you have a p53 mutation, there's not a lot to do. GATA, about a third have estrogen receptor mutations in them. A few people have actually HER2 mutations, so HER2 tyrosine kinase inhibitors, drugs like lapatinib, neratinib can actually be used about probably 5 to 10% of the time. You actually have a ESR mutation, or actually a mutation in HER2. So we can take these women who are estrogen receptor positive and give them anti-HER2 agents, and they actually respond to them. Or if you have amplification of the receptor for estrogen, which is down here somewhere, it turns out that you can give high-dose estrogen, something we used many, many years ago. Didn't know why. It turns out if you have an estrogen receptor amplification, you can use high-dose estrogen as well. And this just shows you back here that these are the acquired mutations. And again, you can see here, these are mutations in the HER2 receptor, and in fact, you can give these patients a combination of fulvestrant and a drug called neratinib, which is a HER2 tyrosine kinase, and these women actually respond. And so this is kind of why I think in breast cancer we're trying to think about doing DNA sequencing to figure this out. And again, estrogen receptor mutations are shown here. About a third of them are in this ligand binding domain, so the receptor actually activates in the absence of estrogen, and aromatase inhibitors don't work anymore. However, fulvestrant does tend to work. As you can see here, in estrogen receptor mutant patients, fulvestrant tends to work over an aromatase inhibitor. In the wild type, they work just about the same. So again, this is a whole other thing. We're getting to the era now in estrogen receptor positive breast cancer where we are actually able, hopefully, to use this data to be able to sequence somebody's tumor and to be able to direct their therapy based on the mutations that we see. These are women actually who are getting a CDK4/6 inhibitor and fulvestrant. They tend to do better with fulvestrant. The mutation doesn't really affect the response to the CDK4/6 inhibitor, but it does affect the response to the exemestane. So again, I think that this is hopefully, I'm sorry that was a little late, but hopefully I kind of gave you a flavor of really what's going on. I think kind of to summarize all of this, I think that CDK4/6 inhibitors have really changed the standard of care in this disease. That estrogen receptor positive metastatic breast cancer is something that almost everybody uniformly died from within 2 to 3 years. And now with all of these agents, we keep people alive at least 5 years, probably 10 years in some cases. And I think that there are some things on the horizon that we may make this even longer. And I think that, I'll kind of end, I'll say, we always wonder, what, not the cure for cancer will look like. And, we always base it on kind of leukemia and lymphoma. And leukemia and lymphoma, you got to get rid of every cell. That's the whole idea. You won't cure leukemia or lymphoma unless you get rid of every cell because the cells grow back. In solid tumors, it's a little bit different. In solid tumors, it's kind of like coronary artery disease. We don't get rid of every single plaque in somebody who has CAD. We learn to medically control it until they die of something else. Well, it's the same thing in solid tumors, and in particular, breast cancer, I think, is the model for this. That if we can kind of turn this into something that's a chronic disease that you live with, that you don't really have to be on very toxic therapy for, that you can live for 10, 15, 20 years, and you'll die of something else, because the vast majority of women with breast cancer do get it in their 60s and 70s. And so the thing is that that's the idea, and I think that at least in ER-positive metastatic disease, that's kind of where we're getting to. We're trying to get to that point where we have a broad variety of agents that we can kind of treat people based on kind of their DNA sequence and then go forward. So again, I'll kind of leave you with that. And again, thank you very much for listening to me. Thank you very much.